good friends, Tom Hendrick, who is a former pilot of the space shuttle. He's piloted the shuttle 4 times. Got up and introduced himself. Hi, I'm one of Dan's friends, Tom Hendrick. I'm a frustrated doctor who became an astronaut. So, and this was the birthday card he sent me this year. How appropriate for a prostate cancer doctor. And the line was, butt jokes never get old. So it's my task appropriately to talk about localized prostate cancer and what are some of the treatments. As we know, this is a heterogeneous disease, and this is an old slide that looks at the issue of PSA and digital rectal exams. And this is particularly relevant to some of the questions we're having now in terms of when should we screen a patient, who should be screened, and the curability of a lesion. Again, it's our ability to be a good physician and to understand the patient, their overall medical condition, how they're doing. But there is a sweet spot in which a patient can be cured. And back to the thought of one of the deans or the godfathers of prostate cancer, Willett Whitmore, is cure possible when it's necessary and necessary when it's possible. And as you see here, we have 4 different patients. Patient D, who's got rapidly progressive disease, has a very, very small window of opportunity in which he can be cured. And patient A, who probably doesn't really need to be treated to be cured. And again, the spectrum as to identifying these patients is extremely important. So what are our options for localized prostate cancer? Well, they include, and not limited to, radical prostatectomy, external beam radiation therapy, and there's controversy as to whether proton beam radiation therapy or IMRT is the best thing to give in these particular situations. Seed implantation, cryosurgery, watchful waiting. Unfortunately, there's no proof that one treatment modality is better than the other. And the way I counsel my patients is you have to make the assumption they all probably have the same outcome. What side effects are you willing to put up with? Well, we have to think about disease risk in taking care of our patients in this situation. And one, of course, is the PSA and biochemical response rate. So when we start thinking about radical prostatectomy patients, if the PSA is less than 10, you've got about a 5% risk of PSA progression. Overall, it's about 30% for radical prostatectomy patients, and it's about 30% if your PSA is greater than 10. If you start adding Gleason scores, you can actually further refine this. It's 8% if a Gleason score is less than 6, 45% if the Gleason score is greater than 7, and then the lower the tumor stage, the less risk of overall PSA failure. So we can actually look at this old publication from Anthony D'Amico from JAMA and looking at the different risk groups in prostate cancer patients. The ones we're going to think about today are those who are the intermediate to high risk patients. The low risks or T2A, Gleason less than 6 or equal to 6, a PSA of less than 10. They have less than a 25% chance of disease failure at 5 years. The intermediates have a 25 to 50% chance of disease failure, and these are patients who are Gleason 7, T2B, and PSAs of 10 to 20. And then any of the other higher risk factors, Gleason score, PSA of greater than 20, they're more than a 50% chance of PSA failure at 5 years. And again, you can risk stratify these patients based upon their chances of having a PSA relapse. The low risk are very, very low chances of having PSA relapse, as you see on the right, and the high risk, approach 50% at a 5-year interval. And there are nomograms. Mike Catan has got one that can be used to assess risk after radical prostatectomy. Again, this is an old version of the Catan nomogram. So we may be increasing our numbers of prostate cancer patients with detection who are low risk. We need to select these patients properly, and then we need to use multimodality techniques for those high-risk patients who are high risk of relapse for prostate cancer. So options for high-risk therapy: you could do a radical prostatectomy alone. You could combine this with hormone therapy plus adjuvant, or radical prostatectomy plus adjuvant radiation therapy. You can have various combinations thereof, and we're going to review some of the data behind using hormones, radiation therapy, and chemotherapy for these patients. So when we look at hormone therapy combined with prostatectomy, we generally do not use this technique as neoadjuvant treatment. There have been a large number of phase 3 trials that have looked at this particular question using 3 months, using 8 months of hormone therapy. And the bottom line is you really don't see a change in the PSA relapse rate at 3 to 4 years post-treatment. And this is generally not used, so I generally will really look at some of these other modalities of treatment like radiation therapy or at least radical prostatectomy as a hormone-sparing treatment. So when we start looking at long-term adjuvant hormone therapy in prostate cancer, this is the only situation except for select patients with a rising PSA that I would offer hormone therapy postoperatively. We're building upon some of the concepts that were used in breast cancer. If some hormone therapy is good, well, maybe a little more treatment is better. And of course, the trial that this is based upon is the study by Ed Messing, which was published in 1999. What he did was he took radical prostatectomy patients who were node positive, and he randomized these patients to immediate hormone blockade versus deferred hormone blockade at the time of relapse. And as we see from the survival curve, there's a significant difference in survival in favor of those patients who receive the immediate hormone therapy. It's about 60% at 10 years for those patients who have immediate therapy, and it's about 85% for those patients who, have delayed therapy. 85% for those patients who have the immediate therapy. And also the same trend can be seen for prostate cancer-specific survival. So what are some of the critiques of this trial? Well, it really doesn't fit the modern era because the median PSA at which those patients received androgen blockade was about 14. So generally, we start these patients earlier. There was no stratification based upon PSA doubling time. This was before the era that we recognized this. And I think what the real trial that we would like to do, which probably will never get done, is hormone therapy immediately versus hormone therapy at the time of first PSA relapse. Does that make a difference? The other issue, too, is that the hormone therapy was given continuously forever. There are those who believe that 2 years of hormone therapy is enough. We really don't know what the optimal duration of hormone therapy is. PFS also was improved, as one would expect, in favor of the immediate therapy. And then we know that, again, in conclusion, it delays progression, improves survival, and the question is more even better, or more hormone therapy even better than this? So we go to a recent trial that was presented at ASCO, and it's been published in the New England Journal of Medicine, the STAMPEDE study. This is a series of different trials that are looking at giving early treatment for metastatic or locally advanced prostate cancer. And this is Nick James' study where he gave abiraterone combined with prednisone plus androgen blockade versus androgen blockade alone to those patients who were diagnosed with advanced prostate cancer. This included patients with metastatic disease, and as you see from this chart, about half of the patients on that trial had metastatic disease. But there are those patients who are node positive, M0, and those patients who had just simply locally advanced cancer and were planned for radiation therapy. And the problem is that we start seeing that there is a significant improvement in survival for those patients who have early hormone therapy overall. It does seem also to be a survival benefit for those patients who have metastatic disease. But the numbers with the node-positive patients are fairly small, and there is a difference in relapse-free survival, but at this point it's not mature enough to look at overall survival. So should those node-positive patients receive abiprednisone plus androgen blockade, I think is a subject of considerable controversy, and you'll find different answers from different opinion leaders. And this, again, is the event-free survival for the study. The hazard ratio is 0.29. Now, the problem is when you're moving other treatments up earlier, you can see other toxicities. In this situation, particularly cardiovascular issues, about 41% of patients will have some form of a cardiovascular event, particularly hypertension, but you also can see MIs and dysrhythmias, and also liver function abnormalities as well. So again, you've got to select your patient properly. So he concluded that this is a standard of care for those patients who are node or metastatic, and the duration of treatments in this trial was capped at 2 years for the node positive patients. So I think, again, we need to see some further follow-up from this trial. What about adding chemotherapy to the initial treatment of prostate cancer? The breast data would suggest that simultaneous administration may not be the right way to go. Marty Gleave had some data that suggests that there was synergy by giving chemotherapy and androgen blockade, and Arif Hussain also looked at a sort of an opposite sequence of chemotherapy, then followed by hormone therapy, and there was some preclinical data that suggested that we should go ahead and do this. As we know, theoretically, there can be hormone insensitive cells present at the time of diagnosis, and that hormone therapy in some patients is not enough to cure these patients. So this was a trial that Tom and I are well familiar with from SWOG, and date back to when we had less gray hairs at that particular point. And this trial randomized patients who were at that time considered to be high risk, T3B, T4, or N1 patients, high Gleason scores, 8 or higher, or T3A positive margins, Gleason 7, 1,360 patients at 2 years of androgen blockade or 2 years of androgen blockade combined with mitoxantrone and prednisone. This trial nearly accrued its 1,316 patients, but the DSMB closed it early, and this was not surprising based upon the breast data because of the fact that there was a higher rate of leukemia in the combination arm of mitoxantrone plus prednisone. So Mike Leday and Maha Hussain has actually written this up in full publication form. This was presented at ASCO last year. One of the important factors of giving hormone therapy in these patients is, do they recover their testosterone once they stop treatment? I think it's relevant to the radiation data when you're giving long-term hormone therapy, but interestingly, nearly 90% of patients recovered their testosterone levels at 18 months post stopping the androgen blockade. Remember, it was capped at 2 years. Causes of death were actually fairly interesting. There were more patients who died from cancer in the combination arm, and these included patients who had pancreatic cancer, patients who had leukemias, as one would expect in the combination arm based upon the early stoppage of the trial, and nobody's really been able to sufficiently explain this. There are other non-cancer causes of death really did not really stand out in either the two arms. But unfortunately, the trial was a negative study. When we look at disease-free survival on an intent-to-treat basis, no difference. And again, about half of the patients recurred. This is a little bit surprising. We thought that we were really selecting a high-risk group of patients. We would have expected a higher relapse rate for these patients. So it basically does tell us in the control arm that androgen blockade does work. But no difference in the overall survival between the two different arms, 87% versus 86%. And that's not significantly different. So it's disappointing, but at least we got the trial done. And perhaps we were not identifying the right patients. Perhaps we didn't have the right chemotherapeutic agent. And that may be answered by a subsequent trial that is being run by Jim Eastham, which is completed accrual. It's a neoadjuvant study of docetaxel given preoperatively, then followed by radical prostatectomy compared to radical prostatectomy alone. And that's been completed. And hopefully we'll see results of this trial in the next couple of years. So what about radiation therapy with these high-risk patients? Combination of radiation therapy plus hormone therapy has been supported by extensive clinical trials. Generally, these trials have used combined androgen blockade. Interestingly, there's synergy between radiation therapy and hormonal therapy, and I really didn't understand this for a long period until recently, when it's been found that depleting prostate cancer cells of androgen will actually deplete DNA repair enzymes. And so now it makes total sense. You deplete DNA repair enzymes, you give radiation therapy, and you can't repair your DNA. You've got synergy. So this I think is now, I think, a good explanation as to why we want to sequence these particular drugs together or put treatments together. The best responses, or at least the best results, do appear to be in those patients who have high-risk disease. It's a little bit more debatable for the intermediate patients. So this particular slide summarizes some of our data that has been generated with using hormone therapy combined with radiation therapy. There's the EORTC trial that gave LHRH for a day, daily for 3 years, showed an improvement in survival. An RTOG study, 8531, giving LHRH beginning the last week of treatment and then continuing with radiation therapy, showed an improvement in overall survival for those patients who particularly were at high Gleason score, 8 to 10. the 8610 RTOG trial gave 2 months of androgen blockade prior to, and then 2 months after radiation therapy. And you also saw survival benefit in also in the lower Gleason score patients. 9202 gave 4 months of combined blockade with or without 24 months of hormone therapy afterwards. Again, the longer survival was seen with the longer hormonal therapy. 9413 gave 4 months of combined blockade with radiation therapy, and again, external beam radiation therapy was the control arm, and there was a PFS difference in those patients who received hormonal therapy. And then D'Amico gave 6 months, 2 months before, and then 4 months after the radiation therapy, total of 6 months, and showed an overall survival benefit. So these are positive trials, and the real question is, how much hormone therapy do you need? So this is the RTOG trial I mentioned before. Localized prostate cancer, they received definitive RT or LHRH progression or the combination. We see a big difference, a significant difference in survival for those patients that are Gleason scores 8 to 10. This is actually the BOLA trial, as I mentioned before, the EORTC study. This was really the first one that showed the big difference. T1 to T4 disease, they didn't stratify based upon Gleason scores, and 3 years of hormone therapy, improved local control, disease-free survival, as well as metastasis-free survival, significant difference in overall survival. And this was the first, as I said before, first study to show a survival benefit. And the question is, do you really need the long-term hormone therapy? These are the survival curves updated from Lancet in 2002, again showing a hazard ratio of 0.51 in favor of the combined treatment. 9413 took high-risk patients, 15% had lymph node positive disease. It also looked at whole pelvic versus prostate RT only, and showed again a survival benefit, and it looked at the role of radiation therapy to the nodes in these patients who had positive nodes. Long-term hormone therapy after external beam radiation therapy, these patients tended to have high clinical stage as well as PSAs, 1,554 patients. Again, as I mentioned before, combined blockade 2 months before and then 2 months during radiation therapy, 65 to 70 gray in the lymph nodes, and then no additional hormone therapy versus 2 years of hormone therapy afterwards. And there was improved in all endpoints except overall survival. And the ones who did have the benefit were the high Gleason scores as far as survival, the 8 to 10s, 81% versus 70%. Question is, does the androgen blockade make up for better or worse radiation therapy? Anthony D'Amico has actually asked that particular question, looking at 3D radiation therapy plus androgen blockade, significant difference in favor of the androgen blockade as well. Just going to move ahead since we're running a little bit short on time. So the question is duration, and this publication came out recently in urology. It was a European study that looked at 630 high-risk localized prostate cancer patients, and they received 36 months versus 18 months of androgen deprivation therapy. 5-year survival rates were similar for both groups, along with radiation therapy, better quality of life, and no significant difference in disease-free survival. So 18 months it looks like also an acceptable number as opposed to the 3 years from Ebola. And I think, again, the number should be anywhere between 6 and 18 months. We talked about this question of dose escalation. It seems that dose escalation gives you a better result overall with localized therapy. I want to answer the final question that we have also, and this shows some new data from ASCO this year, looking at the role of chemotherapy in the situation, since again, we're trying to move some of our treatments up front and earlier in these patients. So this is a study from Finland, phase 3 trial giving adjuvant docetaxel chemotherapy after radical radiation therapy for intermediate to high-risk prostate cancer patients. And so as we see here, patients were randomized to docetaxel after their radiation therapy or surveillance. They did not receive continuous corticosteroids. It was given for 6 doses, just as has been done in the Charted trial. As you know, I think this is not, to me, surprising as far as our results are concerned. Again, high-risk patients, Gleason score 4-7 with T2, PSA of 10 to 70, or Gleason 8 to 10 with PSA of less than 70, and all patients were required to have hormone therapy prior to, or at least along with their radiation therapy. Median PSA of 14.6, predominantly T2, T3 disease, and all these patients in good performance status. And unfortunately, we didn't see a difference, no difference in progression. And when we start looking at progression-free survival, no difference in progression-free survival. And the group that may actually do better with the chemotherapy are those patients with the high Gleason scores. And we see this from the forest plots from the particular trial. So chemotherapy is not indicated in my mind for these early prostate cancer patients. I think we need to see the results from the Eastham study before we, what's otherwise known as the PUNCH trial, before we start implementing chemotherapy earlier. But the important message here is that high-risk prostate cancer is curable with multimodality therapy. We don't use androgen deprivation therapy prior to surgery. Its role is limited to the postoperative setting, and therefore I actually view androgen deprivation therapy as radical prostatectomy as a hormone-sparing procedure. If you have a patient who you're concerned about with the long-term side effects of ADT, I tend to push these people more towards radical prostatectomy. The optimal duration of radiation therapy combined with androgen deprivation therapy is not clear, and I think 18 months is probably acceptable. Perhaps we can get down to 6. And then, as I mentioned before, chemotherapy should not be routinely used for these patients with high-risk localized disease. I'll turn the podium back to Tom. Thank you for your attention.